Yeah.
Hello there. I'm Gordon Taylor, and I'm going to go through psychiatric therapies, biomedical therapies associated with psychiatry. Some of the definitions that you're going to get into are confusing. And so we're going to talk about psychoactive drugs, which are drugs or medications that affect mood. Psychedelic drugs are basically recreational, and when they become a medication is when they're psychotropic and they're given for mental illness. So medications that are used for mental illness are drugs like Prozac, or Paxil, or Zoloft. Those drugs are mainly used for depression. The other main mental illness that's out there is schizophrenia, which is a thought disorder. And a recent drug, Haldol, has become available to help with some of the symptoms associated with that. If we look back into the history, prior to World War II and into the early 1950s, patients with mental disease, whether they were on medication or not, were institutionalized. However, in the 1950s, patients on medications were released. Because when they were on medication, things seemed to go very well for them. But patients to be released from mental institutions on medication, it really does depend on compliance to take those medications. Now, the medications we're talking about have a long time to take effect, somewhere in the region of about 4 weeks. And similarly, if the medication doesn't work or is losing its effectiveness, then it takes about 4 weeks for the effects of the medication to wear off. So we have a fair amount of confusion associated with patients who are mentally ill and patients who are self-medicating and on substance abuse drugs. And this is where I try and stay with, if the medication is being used for mental illness, we call it medication, and if it's a chemical that's being abused, then we call it a drug. And so the first three of these 6 groups are, number one would be the institutionalized patient, who's being protected not only for their own safety, but safety of those that are around them. The second group is those patients who would normally be institutionalized, but now they're on medication and have agreed to be compliant with taking that medication at home. The third group is a mentally inpatient who at the start was on medication but fell off the wagon for whatever reason, and it doesn't really matter, and they've either started to self-medicate or, as usually the case, they're non-compliant as far as taking their medication that they agreed to. The second three are a bit more serious. The fourth group are patients that have been abusing drugs but are showing signs of mental illness. And on occasion it's really difficult to decide whether or not the mental illness was there to start with, or whether it is as a result of the abuse drugs. The fifth group of patients, which is becoming a larger and larger group, are patients who are in recovery and who have made it to be abstinent from the drug of their choice, and somewhere along the way they have had to have surgery, either orthopedic surgery or dental surgery. Usually as a result of surgery, there are a few days afterwards that are painful. And one of the drugs that's used to help this is, of course, OxyContin. And OxyContin, as some of you may be aware, is a really bad addictive drug. A number of these patients, if they're not monitored carefully, will go back into drug abuse. And this is sad, really sad, because they've made the effort to be into recovery, but now have slipped off the wagon. The sixth group is just that group of that are abusing alcohol and other drugs, and it's that group that have got to make their way up through these six groups. If we look at history in a little more detail, society's way of dealing with mental health in the 1600s to the 1900s was to warehouse those patients or institutionalize them. And that was really a sad state of affairs. There were some sedative drugs that could be used, but basically speaking, there were no chemicals or medications that could be used at that time. In 1921, insulin was discovered, and it was a lifesaver for many patients who have diabetes. This is type 1 diabetes I'm talking about. And as a result of some patients probably taking an overdose, Some of them were seen to have a convulsion. And so insulin shock therapy was born. And there is no doubt that if you give large doses of insulin, that some patients will become comatose as a result of a convulsion. Now, the cause of the convulsion is to deny the brain cells sugar, which is not a good thing. And so insulin shock therapy for depression had a short life. In 1938, the first ECT was done. Now, ECT, or encephalocconvulsive therapy, was designed to put electrodes across the frontal lobes, or on the side of the forehead, if you like, and throw a current between those two electrodes. The patient would have a convulsion. The convulsion would be very similar in many respects to an epileptic convulsion, and they would sleep and not remember the convulsion. And if they had depression, some of those patients were really helped. Now, to put us in a time frame, the time is around 1941, Pearl Harbor. After the Second World War, muscle relaxants were discovered, and they were able to modify the convulsion of the ECT. Now, I'm really talking about real muscle relaxants. The lay public seem to think that Valium is a muscle relaxant, and really it isn't. If you use big enough doses, it's just a very good sedative, which is in fact very long acting. So the muscle relaxants modified the ECT, and those patients with depression were substantially improved, particularly if they were female and in the menopause age group. We then had, in the 1960s and 70s, an explosion of mental health drugs. These chemicals came onto the market and were quite successful if specific groups of patients were used. There were three types of drugs: anti-anxiety, antidepressant, and schizophrenic. Now, once these chemicals, and we need to call them medications because they were given for a medical need, some patients in mental hospitals seem to be ready for a home environment. And the term that's used around this particular procedure is deinstitutionalization. In other words, taking the mental patient out of the monitored confines of an institution and putting them in a home environment with a medication which usually has to be taken each day, and the patient is then deemed to be compliant. So really, we've just talked about chemicals or medications, talked a little bit about drugs and drug abuse. We're going to move to what surgical procedures are available to patients with mental illness. The one that goes back the longest is burr holes, and simply put, the patient has a hole drilled in the side of their skull usually, and with a drill and a bit, and in olden days, say 2,000 years ago, if the burr hole was over the right spot, it would leak out the blood that had accumulated. This sometimes was successful and sometimes was not successful. One of the extensions of burr holes is trepanation, which really means that you drill 3 or 4 holes in the skull in order to get at blood that may have accumulated, and connect those holes together and take this piece of skull off. This is really very good at relieving whatever pressure might have accumulated from blood seeping into the brain and the skull. Other surgical procedures, well, we need to talk a little bit about convulsions and epilepsy, which has a place here. If a patient has a convulsion, they will usually become comatose and might vomit, but then has a period of sleep and unconsciousness, and they don't usually remember the convulsion. There's a fair number of patients who have epilepsy. Some have 1 convulsion a day, some have many convulsions a day, and it was it's really a very unfortunate illness. There are some medications that would be helpful. Anybody having a convulsion really has to be monitored very carefully so that they don't aspirate their own vomit. Insulin shock therapy, very similar in symptoms with convulsions, occurred in the 1920s, but it's based on denying sugar to the brain cells, which is not a good idea. Electroconvulsive therapy was used in the 30s and into the 40s and 50s, really only of value with patients who have marked depression, and in particular to the group of patients, menopausal ladies who have depression, often see value in ECT. ECT is of no value in schizophrenia. Other surgeries that were done over the years, immediately after World War II, in the 40s and 50s, when chemicals were not available, lobotomy was done for mental illness. In many cases, this was catastrophic. And lobotomy means amputating the frontal lobe on one side or both sides, and it was not a good treatment and was discontinued in the early 1950s. The main surgical procedure today for patients with mental illness is the excision of an epileptic focus in the motor part of the brain. The motor part of the brain is situated between the nose and the occiput, right in the middle of the skull. There have been a number of very successful treatments where they've been able to excise the epileptic focus. The procedure has changed over the years and usually was excised using a scalpel, and then a scalpel that was attached to the cautery, and it was found that heat was very successful at limiting the amount of bleeding that occurred with just a surgical incision. What happens is that the cautery is very useful, provided you've been accurate in identifying the area on the motor cortex of the brain. The heat keeps the bleeding under control, but it may be necessary for more than one attempt at the procedure in order to get a good control of that epileptic focus.